Good morning, everybody. Good morning, everybody. Welcome on a lovely June Monday morning. I'm Dr. Andrew Kleek, and I'm the co-director of the Managed Care Technical Assistance Center, and I want to thank everybody for coming today. We are going to start giving the 30,000-foot view of what HCBS services are going to look like today. Just by show of hands, how many folks are here from a managed care plan? Okay, couple. How many folks are here from HCBS provider agencies? All right, good. And then how many folks are here from health homes or health home care management agencies? All right, so we got the right people in the room. Very, very good. A couple housekeeping things before I dive in. We are going to go from 9 to 12-ish today, and then we have a whole nother group coming in the afternoon. The presentations will be identical, so there is absolutely no reason to stay for both of them. They are filming this morning. The filming will be very unobtrusive. It's just two cameras in the back. And we will take all of this today and we will put it up on the web with the slides. You should have gotten the slides on Friday if you were registered. If you didn't, we will put them back up on the web after the thing, so don't be nervous about that. We did not print the slides out today just because 700 copies of slides in a size that would be legible would have been really frightening and killed a number of trees. So we didn't do that today, but there are some important handouts on your seat, and I'm just going to grab one real quick. Hold on. All right, so you have the all-important feedback form. We strongly encourage you to fill this out at the end of the day. We will remind you again before you go home. But the feedback is really important in terms of what worked, what didn't. There is the who's in and who's out of managed care slide, which we'll go through later, so no need to do that, but you've got that as well. And then a slide on the workflow for managed care to get somebody in HCBS service, as well as the conflict-free. All of those things are draft, and we also put a notes page in so you can take notes. So that's the stuff that's on your chair. We will not be handing out extra copies today because we're expecting to have more people this afternoon, probably about 400 or so. But if there's a copy on the chair next to you and you want to take it for a colleague, that's fine. If you have folks who are unable to come today, again, we're taping this morning. We'll put it up on the web. It'll probably take a couple weeks for us to get that done. We will be taking a couple breaks for questions. And so I just want to highlight, we said this when we did the kickoff events, but I want to highlight this today. We've got Gary and Bob here and Lisa Light-Rotman from OASAS to answer questions. But all the Q&A we will take, we'll have somebody taking notes during all the Q&A, and we will write up all those notes. What comes out in the written form of those notes will be official, and everything that comes out in the discussion form of the questions will be considered preliminary. So you'll get the 95% answer, and then the official written format will come out later. Most of what we're presenting today is at the very, very high level. It is not a granular overview. There will be much more training coming forward, which I'll talk about in a second, to do that. But we wanted to really get started on what HCBS services are going to look like and the workflows for things like that. There will probably be some changes in some of those things around the margins, but probably not in a large way. So before we dive into the program, I'm just going to give you a little bit of idea kind of what MCTAC is and those kinds of things. Bob Myers is going to talk us through really the vision of HCBS services, and Lisa Light-Rotman from OASAS is going to talk us through kind of the way it applies to substance use services. We're going to go through the key components of HCBS services, the things that cut across all the services. We're going to go through that to the extent that the policy is kind of sorted out there. We're also going to go through the first of those slides I showed to you, kind of who is in managed care and who's still carved out of managed care. As we all know, the vast majority of folks are going to be carved into managed care, but there's a couple little finicky things about folks who are still carved out, so we're going to try to walk through that today and make sure that folks have a really good sense of that. Then we're going to walk through the workflow for how somebody goes from being in a HARP to actually getting an HCBS service. It's a little bit of a stretch and a little bit of a complicated process, so we're going to walk through that to the extent that it's identified at this point. It is considered a draft, so it might change a little bit as we go forward. We want to give folks enough time to start to think through how they structure their systems and stuff like that. And then we're going to go at I like to say 30,000-foot view, but I think this is about a 50,000-foot view about each HCBS service, and then we'll take some questions and then wrap up and get folks out of here. Just for logistics' sake, if you haven't heard, it's been all over everywhere, but the go-live date for New York City-based providers for managed care is going to be October 1st. And then for folks outside of the city, the start date will be no earlier than April 2016. And for kids providers, they're looking at 2017. Managed Care Technical Assistance Center, we're a consortium built of a number of different partners who are part of MCTAC, and then many others like CPI who also work very closely with us. So we're made up of the McSilver Institute, where I work, and Casa Columbia, who helps us out on the substance use side, CCSI, which is a management services organization which helps us out in the business side, and also coordinates a lot of our work upstate. ICL, which in this room folks are familiar with, is a large multi-service provider, NIAPRIS, and then IDEAS, which is a New York School of Medicine. Our goal at MCTAC is really to work with all both substance use and mental health agencies in New York State. There's about 877 of them at last count, and our goal is to work with every single one of them to help all of you make this transition to managed care as seamlessly as possible. We all know that there will be bumps in the road along the way, but we're working as close as we can with government as well as providers to really make that transition go as smoothly as possible. There are a number of trainings coming up that I just want to highlight for folks. Announcements on some of this stuff will be going out tomorrow, and if not tomorrow, then very, very shortly. You are at the first one, so you successfully registered for the first one on HCBS services. We're going to do an HCBS webinar series that's going to go through the next several components of HCBS, really each of the individual services in more depth. It's going to start the week of July 7th and run through the 24th. That first week may get moved a little bit just because of the managed care readiness reviews that the state is doing with providers, but we're going to do that in July. We're also in the middle of doing a contracting web series. If you haven't signed up, shoot us an email and we'll get you signed up. I think there's like 250 agencies or something like that signed up for that already, which is going to really walk through step by step the things to look for in contracts. We got some feedback after our last contracting events that people wanted a little more in-depth stuff and some checklists, so we're going to be rolling that out starting in, I think, later this week, actually. So starting later this week and rolling forward. The other thing to let you guys know about is we're working in the background with all the plans to develop an integrated set of billing guidance. So that and this is not for health homes, but for state plan and HCBS services, Boris and I have been literally going through line by line the UB04 form, for those of you who are finance folks, and walking through each field and what goes through each field so that you don't have to go to 10 managed care plans and get their take on how do you fill it out, but we'll have one set of integrated billing guidance for folks so that you have one kind of nonstop, one-stop shopping. Does that sound like something that would be helpful to people? Okay. So that'll be ready in August, probably the very beginning of August, hopefully in time for people to start to orient their systems and that kind of stuff. We have another meeting with the plan set up in the next couple days. We will also be doing plan of care training. There's a lot of work in the background going on with both the plans and providers and the state sorting out exactly what's going to be in the plan of care for HCBS services, and we're doing a lot of work in the background on that. And as soon as that's ready, we'll probably be rolling that out in the fall because the actual HCBS services don't start rolling out until January, so we have a little bit more time there. This is the tentative schedule for the HCBS trainings. I'm just going to say that the one on psych rehab may get pushed a little bit just because of some of the things I just mentioned. One other thing I want to mention on training is that we are going to be going live with something we're calling the Matrix very soon, which is going to have all the plans information in it, so you'll be able to look up and find out who are all the people you need to talk to at United or who are all the people you need to talk to at Health First. We figured that was going to be something that people were going to have to do individually, and it's something that if we do once, we can get it up there for folks, and they don't have to do that at their own individual agency level. So we expect that that's going to go live in the next couple weeks. We have most of the plans information back now, and we're just looking after the last couple to get their information, and then we will be all live with that. So again, I think that's something that will be helpful. It'll be all online. You can download it. You can look at it online. Literally, you'll be able to go online and click on a map of New York City and say, who are the plans in my area, and they'll all pop up. Again, helpful? All right, good. So if you have any questions about MCTAC, you can either shoot us an email at mctac.info@nyu.edu, Morgan, who is checking people in outside, is the person who mans that. On simple logistical kind of questions, we get back to you pretty quickly. If you have policy-related questions and things like that, it takes a little while because we either have to answer them internally or we have to send them to the state. But feel free to shoot us emails at that email whenever you need to. And also, MCTAC.org is the place where you find all the information about managed care services and the transition to managed care. And the slides and the video from this will be up there as well as all of our past training. So if this is the first time you've ever seen my face in front of a room, there's a bunch of stuff on MCTAC.org you should probably take advantage of and go take a look at, okay? All right, so with that, I'm going to turn it over to Dr. Bob Myers from the State Office of Mental Health to talk through the HCBS vision.
Thanks, Andy. I'm really looking at the rehab and recovery part of the system, looking at you folks out there now, which is my favorite part of the system. And I really think of you as the future of where we're going. If we get this right, if we do this right, we're going to really help people. We're going to help people stay out of the hospital. If we get this right, we're going to help people to get jobs. We're going to help people improve their functioning so they could be more independent and empowered, go to school, and we're going to really help people recover. So that's what we're really talking about here. So you're going to hear today a lot about billing, managed care contracting, how do you apply for an NPI number so you could bill Medicaid, plans of care, federal rules around HCBS services, and that's all really important and critical. But what I'm going to talk about first is what we're trying to accomplish, why we decided to bring these additional services into the benefit package. I think it's important to keep that in mind. It's also important as right now you're thinking about the technical aspects of what you have to do to become a provider of these services. In the long term, you're going to thrive if you produce person-centered outcomes, and you got to think about that from the beginning to organize yourself that way, or over time you're not going to be successful. The first thing I wanted to explain is from the federal Medicaid perspective, what home and community-based services are. The concept's a wonderful concept. So think of the word home and community-based services. And many years ago now, the federal government came up with this idea, and the idea was if we put the proper types of supports in the community, we could keep people out of institutions. Now, initially, it didn't apply, especially to adult mental health, because of the Institute for Mental Disease issue on the federal level. But the federal government has numbers associated with all their managed care approaches, and for home and community-based services, it's 1915. So they had this thing, 1915C, and New York has applied for that in many ways. New York State has an HCBS head trauma waiver. They have a nursing home diversion waiver. At the Office of Mental Health, we have a children's HCBS waiver. Now, initially, the only people that could have access to those were people that were at significant risk of being institutionalized. The federal government said these HCBS services, home and community-based services, were put in place to keep people out of institutions or to get them out of institutions. So, we've used it to keep a lot of kids out of RTFs and children's hospitals. I actually know somebody at the Office of Mental Health who, unfortunately, their brother had a serious accident a while ago and had head trauma, and he's in the head trauma waiver. And 15 years ago, she said he would have been in an institution. Instead, she's helping with the case management, and he lives in his own place. So after a while, the federal government said, well, can these services be useful to people that aren't at imminent risk of institutionalization? They came up with something called the 1915I suite of services on the state plan side, not the managed care side. New York didn't apply for that because there was a lot of baggage with it, and we had rehab option services like PROS and ACT. But when we started to work on managed care, now again, federal numbers, there's something called an 1115 waiver. That's what New York uses for its mainstream managed care plan. So all the managed care companies that you're relating to now get funding through this 1115 waiver. We have to amend that waiver in order to bring the $1.5 billion worth of behavioral health money into these benefit packages. And we learned, working with our consultant, that we could add HCBS services that way. And we started to look at it, and we started to say this would be a good thing to do. And again, these services aren't just targeted to people that are at risk of institutionalization, but the federal government is saying a couple of things. They're saying, well, there are people that aren't at risk of institutionalization now, but if they don't get good community supports, they could well be institutionalized or hospitalized in the future. And I also believe that there's people that are institutionalized in the community. They're isolated. They may be in homeless shelters. They're in adult homes. And these HCBS services are supposed to wrap around people and have them become more independent. So that's the concept of HCBS. Now, because it's targeted to vulnerable populations, you have to actually identify the definition of who you're targeting your HCBS services to. The federal government views this as a very vulnerable population. They want to make sure that there's protections and insurances in place to make sure they're getting these services that the state has applied for. So with HCBS services, it's baggage on the one hand. There's a whole bunch of things we have to do that we wouldn't have to do, but we still decide to apply for them because we think they're going to be, a wonderful addition to the system. So what are assurances? And this will explain some of the things. First of all, if somebody is eligible for HCBS services, they have to have a comprehensive assessment. And that comprehensive assessment has to be an instrument that's been tested and proven that it's accurate. So different states have chosen different instruments. New York has chosen the Inter-Eye tool, which some of you are familiar with now. It was developed out of the University of Michigan. It was originally targeted to a long-term care population, and New York's using it for its FIDA programs, its nursing home diversion programs. But there's a mental health suite to that. So we're going to be using that for HCBS services. And I know that some of you that are care managers in health homes, you're going to have to go through extensive training to learn how to use this instrument. So the first part of it is there has to be a comprehensive assessment. And then the federal government's saying, well, you have to make sure those assessments are done well. So we're going to have to, spot audit some of these assessments to make sure that they're done properly. And then they're saying you have to make sure that if there's identified needs and if people are eligible for these HCBS services, they actually have to get them. So those services have to appear on their plan of care based on what the assessment says. And then the federal government says, well, they can't just be on the plan of care. You have to make sure the people actually get them. So we're going to have to put processes in place to make sure that the people that have these rehabilitation-oriented services on their plan of care actually get them. We'll be able to look at Medicaid payment data for that. And then one more thing, they want to make sure that people are assessed on a periodic basis to make sure that have their needs changed and do they need another combination of services. And all these things are called assurances. The federal government wants the state to assure that the people are actually getting high-quality HCBS services. So that's why we have the Inter-Eye assessment. That's why that it's going to be on a plan of care. That's why we're going to track it. And one more thing, they have to make sure that the people have choice in services, and this is where the concept of conflict-free case management comes in. We're going to have to assure that if a care manager is working for a specific provider, not all the services on that plan of care is steered to the provider organization they work with, but the people have choice. So if they want an employment service or mobile rehab, and in their community there's 3 different organizations that do that, we're going to have to demonstrate that the people have choice of services. So that's, if you're wondering why do we have to do this assessment? Why do we have to do these things? What is this conflict-free? It all comes from a very well-intentioned issue on the federal government's part that these individuals are vulnerable. The state's applied for these focused services, and we need to make sure that the people are getting those services. So I wanted to give you that background so you understand where all this other stuff is coming from. So what do we want to achieve with these HCBS services? And again, think of HCBS services as a complement to the existing benefit package we already have. In New York State, on the mental health side, we do have rehabilitative services. We have PROS. There's rehabilitation built into ACT. There's rehabilitation built into our housing programs. But they're more like an organized program where HCBS services are kind of like a menu of services that'll complement other things. So when you think about the illnesses of the folks that you work with, there's There's positive symptoms like hallucinations or affective disorders like depression or mania. There's anxiety. There's substance abuse. These things often occur together. How many people do you work with that have a psychotic disorder that are also dealing with depression or anxiety or substance abuse? So those are the active symptoms. And we've made, I think, pretty good progress there through a combination of therapy, support, and medication. We have a long way to go, but if you go back and look what it was like in the 50s and 60s before these treatments, many more people were institutionalized. So we've made progress there. Then there's the negative symptoms about self-care, managing in the world, motivation, focus. And through some of our rehab services, we've made progress there. And neuropsychologists would say, well, the cognitive effects of these illnesses create some of the negative symptoms like processing speed. Some folks have trouble doing things at a reasonable pace or executive functioning, being organized or planning how to, if you want something, how to get there, or just the overall focus. So people have struggle with work or school or community integration. And so how do you address that? I think in our business, you talk about technology in businesses. We have a psychiatric rehabilitation technology, and it's actually been demonstrated through research that if it's done properly, with properly trained people, it actually works. So what we're trying to do with these HCBS services is to use evidence-based approaches and a trained workforce to try to focus on the basic thing we're going to be focused on is functional improvement, helping people to overcome the cognitive and the negative effects of the illnesses they have so that they could function better. So by helping somebody increase their functioning, first of all, they're going to be able to manage their life better, they're going to be empowered, they're going to be more independent, and then they're going to be able to achieve their goals. I think most of you, when you talk to your clients and you ask them what they want to do, it's not necessarily, I want the voices to stop, or I don't want to feel as depressed. It's like, oh, I'd really like to have a job, or I'd like to live in a better place. People's goals are usually real-life goals. The effects of their illness get in the middle of it. So, that's what we want to focus on, functional improvement. But functional improvement focused on an outcome or a goal, which is where person-centered planning is going to come in. You engage the individual in a person-centered way, determine what they want to achieve, and then from a clinical perspective, determine what aspects of their illness may be impediments to that. And then you start to work with them around improving their functioning. If you go back to the old Psychiatric Rehabilitation 101 that came out of Boston University with Bill Anthony, the idea would be you engage somebody, you determine what their goals are, you determine what skills they need to achieve those goals, you determine where do they have problems with those skills. You focus rehabilitation on trying to restore that functioning, and in areas where you can't fully restore it, you wrap supports around the person so that between the combination of rehabilitation and support, they could have what they need to achieve their goals in a person-centered way. So that's kind of in a nutshell what we're about. I mean, that's a mouthful. So how do you do this? You have to engage people, you have to motivate people, you have to assess their needs, and then you figure out where functional improvement could come in. You have to maintain the gains you've put in place in a person-centered way. And there are evidence-based approaches to that. There are best practice approaches to it. But in our business, no matter what we do, anywhere in the levels of the system, whether it's reimbursement or rules or anything else, nothing matters unless the interaction between the frontline staff person and the individual is done in a respectful, person-centered, quality way. So that the training of our workforce is going to become very, very critical. And we're going to really focus on that. We're actually, many of you have been designated to be HCBS providers. We're going to put some requirements in place that on an annual basis you have to demonstrate that you've done staff development at the front line level and at the clinical supervision level, because we know that there's a lot of turnover on the front line. You're going to need to build into your organization good quality clinical supervision to make sure that your staff are trained to the maximum level that they can be trained to produce the outcomes we want to produce. So with that, I'm gonna go over the menu of services and why we applied for them, and then in a bit, Boris is going to go into more details about those. Let's see if I can make this work. Yeah, these. But by now, I think you're familiar with these services. And when we realized we could apply for these services, we decided, well, which ones do we want to get? So, we focused on basic rehabilitation, psychosocial rehabilitation. CPST is like a paraprofessional and a professional level. And then I'm putting habilitation with that too. And I even struggled this myself with our consultants. What's the difference between habilitation and rehabilitation as it applies to behavioral health population? Rehabilitation is supposed to be helping people restore skills they've lost, like on the physical health side. Somebody had a car accident and they hurt their shoulder, and the doctors fix it up medically, but then you have to go to physical therapy to restore your range of motion. Or somebody had head trauma and you try to restore their functioning to the maximum you can. Habilitation is supposed to be giving skills that people never had. Now with our population, that's a fine line to walk. So what we're going to be saying is that we're going to be thinking of habilitation and rehabilitation together as a continuum, and our consultants say, in a way, it's a billing coding issue. As you're providing services, you need to determine, are you restoring somebody's skill, or are you helping them to get a skill they never got? So we're saying that providers that provide rehabilitation and habilitation have to provide those together. We're not going to have a situation where that's split, because with this population, it's really not possible. Crisis services, initially we applied for mobile crisis services through HCBS too, and then working with our consultants, we determined we could actually put that in the overall benefit package. So we are going to have Medicaid reimbursement for mobile crisis services. It's not going to be in the HCBS package. Everybody in the managed care plan will have access to it. But we wanted to focus on helping people stay out of the hospital, and that's an important point. We're not just focusing on high-end recovery goals of employment and stable housing and more integration in the community. We're also focusing these services on people that are really struggling with their functioning, and they're in and out of the hospital all the time. So these crisis residential services are really to divert people from having to go to hospitals and emergency rooms. And we're having two levels. One's more of like a paraprofessional peer-operated type respite, and the other one's a more intensely staffed professional level where we're actually going to be diverting people that would have to go to the hospital or the ER if it wasn't for these services. And I think over time this is going to become very valuable. In some other states that have done this properly, they really have brought down readmission rates. And then educational supports. In New York, we never did bring Medicaid into education. We had wanted to do that with PROS, but with the federal government's approach to working with New York around state plan amendments, we were never able to amend PROS to bring supported education in. So we're actually going to have Medicaid behind supported education. Now, as we do technical assistance on this going forward, you're going to have to make sure you don't cross the line between what Access VR, VESA does. And then we're going to have a range of employment services. When I came to the Office of Mental Health, almost 30 years ago now, the unemployment rate of the population was 85%, and it's still 85%. And if you look at people with really serious illness, say like in the PROS program, the unemployment rate's in the 90s. So we haven't done very well with this so far, and we said, well, let's keep trying what we're doing, but let's also try another approach here. Peer supports, we really have a lot of hope here that be able to bring Medicaid into peer support services, and the peers that get reimbursed under this category have to be certified. Both OMH and OASIS have a peer certification program, and I know a lot of peers are going through that. We view peers working throughout the system. Now, there'll be peers working in other areas of the system that won't be billing under this. We have peers on ACT teams. We have peers in PROS programs. OASIS has peers in many of their programs. But we're also having a focused peer service that if a peer is doing that type of service, like peer bridging, for example, they'll get reimbursed under this, and they have to be certified. Family support and training is just a critically valuable service. The research shows that if you do that properly, you get much better outcomes. We think it's really underutilized, and by bringing Medicaid into it, we think we'll be able to have that grow. I think we have a lot of work there with the system in general to use the service more than is happening. Non-medical transportation, it's just, Medicaid will be able to help people to use transportation to achieve their goals. People have to realize that this has to be on the service plan. You might be able to transport somebody to a job interview. It's not just paying for somebody to go to the grocery store or the movies. It's transportation loaded to a goal on their plan. And then self-directed care. Self-directed care has been used for a while now on the physical health side, and even in the OPW world, but not a lot in the mental health and substance use self-help is used, and mental health self-help is used, but that's different than self-directed care. Self-directed care is you actually have an organized program where people could make decisions about how the dollars that they access are used, and even hiring or firing, quote, support staff. So because this hasn't been thought through a lot in mental health yet, we're not going to put it in the benefit package initially. CMS has given us, or we're working for CMS to give us the permission to pilot it. We hope to pilot it for a couple of years and then go back to them and put them in the benefit package. So this is a future thing. So I want to focus for just a couple of minutes on who actually applied for these services to give you a sense of the range of organizations. So far 171 organizations have been designated to be HCBS providers, and most of those are down in New York City. We opened it up to upstate New York, but haven't really looked at those applications much yet, and outside of New York City we're going to get a lot more applications. But when you look at it, I won't go through all of it quickly, but a high number of organizations have applied to provide these various services. So the first thing this has said is not every organization says they either want or could do all of these services, but many organizations are saying they could do a lot of these services. Now remember, what we said was that we designated you based on your application and your description that you have the skill level and the competency in the workforce to do this, and that you would provide it in the way that was described in the manual. But that by getting the designation, there's no guarantee you're going to get into a managed care network or you're ever going to get paid to do any of these services. It's kind of like you have to, it's a pass-go, but it's different than if you got a clinic license or if you got an ACT team, or in the old days if you were targeted for targeted case management. All it is saying you're designated to do it. And it's almost like I use the example of, say, if you got a taxi cab medallion, if you don't get hooked up with an organization and you don't get a cab, and when you're driving around the street, people don't actually come into your cab, just the fact that you have the medallion doesn't mean you're going to get business. So I know that through MCTAC and other ways, through your leadership and your agencies, you've all been out there working to get into managed care networks. Now, this is interesting. When you look at the range of organizations, this is the 171 or whatever it was, 71 of them were OMH licensed, 29 OASIS licensed, 44 had both licenses. Only 27 of the organizations we've designated so far never billed Medicaid. There really is an issue about organizations that are never billed Medicaid. We have to help them a lot with technical assistance, but it's a significant minority of the total. Most organizations that have applied to do this are already Medicaid providers and have some organizational capacity to bill Medicaid. So that's just kind of summarizing what I said. Why the numbers don't equal on the two slides, I'm not sure. And then the other part of it is 17 of the organizations that applied were Article 28 hospitals, 148 were community-based organizations, and 6 were state hospitals. So the vast majority are community-based organizations, but larger organizations have also applied to do these services. It's going to be very interesting to see how this whole thing plays out. I think for community-based organizations, you really need to make sure you get to the table. I do believe that in many cases you have the workforce that have the skills and knowledge of psychiatric rehabilitation. So I wanted to make the point that this is different than what you've done. I've heard a lot of things like, we've been doing this stuff for a year, or just designate us and let us go. First of all, it's Medicaid, so there's got to be a plan of care, there's got to be an assessment, there's got to be goals, there's got to be progress towards the goals, there has to be accountability. You have to change the plan of care if people aren't making progress, and between the managed care company and OMH, we're going to look at that periodically. Periodically, you'll have to have a conversation with the managed care company about, well, is this person making progress towards their goal? If they're not, how do you formulate the plan of care, or is this the right service for them? So, but beyond that, as I said earlier, it has to be staff development. You're really going to need to focus on the quality of the interaction and the technical ability of your frontline staff working with these individuals, and the clinical support and supervision they get from your organization. So you're going to focus on engagement, motivation, functional improvement, person-centered functional improvement based upon people's goals, and outcomes. You're really going to have to focus on outcomes. So, 3 years from now, if one organization saying, if somebody comes to me, there's a 40% chance of them getting a job, and another organization, there's only a 10% chance of getting a job, that's going to be made public. And I think people are going to vote with their feet in managed care organizations, because we're going to incentivize managed care organizations to focus on recovery outcomes. They're going to steer business towards the organizations that get the results. So on the front end of this, as you're thinking about all this technical stuff about how do I bill Medicaid and get my computer systems in place to do this, and how do I put my corporate compliance in place to make sure if I'm audited, I'm clean, you need to focus from the very beginning on the quality of the interaction and the skill level of your staff, or going forward, if you start to get business, you're not going to keep doing it, because we're going to look at results. So with that, I think Lisa's going to come up from OASIS and talk about how this pertains. And I'm going to talk for a little bit after that about the care planning thing.
Good morning, everyone. Hi, so I'm Lisa Light-Rotman from the Office of Alcoholism and Substance Abuse Services. I work in the Division of Practice Innovation and Care Management, which is a relatively new division in the state. So in addition to everything that Bob said, OASIS had...
Put your slide up. I'm sorry, I forgot to do that. There you go.
Sorry, thank you. OASIS also had a vision about how HCBS could further support the individual with SUD. Bob mentioned that there was a cross-section of programs that were designated, and OASIS had a particular interest in encouraging all community-based providers to apply for designation. We wanted to make sure that there was an expanded service capacity in the system. So many of the providers, such as recovery centers and other peer support services, employment service providers, alternative to incarceration providers, and others, harm reduction providers, applied for designation. They were already delivering services to SUD individuals, but this would enable them to expand their service capacity. OASIS was also interested in engaging providers that outreach to some of the most difficult individuals to reach, but in natural settings. This HBS service might be more attractive to these individuals because they have challenges sometimes accessing services through some of the more traditional pathways to service. In addition, SUD individuals basically demonstrate or experience the same deficits in terms of cognition, motivation, emotional regulation that those others with other severe mental health disorders experience and can benefit from the same type of interventions. What's important is that the service, the HCBS service, basically acknowledges the unique service needs and the unique service pattern of the individual with SUD, and also recognizes that the specific impairment of the individual with SUD. And finally, OASIS is very interested in working with providers to create service models, HCBS innovative service models that could better serve the individual with SUD. And now I'd like to invite Angela Lockhart and Brenda Harris-Collins from OASIS, who will speak about some of the unique needs of the individual with SUD and how some of the services from HCBS would apply to them specifically.
Good morning. My name is Angela Lockhart, and I am the statewide VR and employment coordinator for OASIS, also in the Division of Practice Innovation and Care Management. I'm going to speak with you about the employment services specifically, and they are the separate and distinct employment services for individuals with disabling behavioral health disorders. The 4 home and community-based individual employment support services are offered to individuals who express a clear decision to work in the competitive employment environment and require support to achieve an actual employment goal. Each of the 4 distinct home and community-based employment services are uniquely designed to support this person along his or her individual employment and recovery continuum. For example, an individual with a substance use disorder may present with a criminal justice background and chooses transitional employment support services as an opportunity to obtain job placement. This opportunity is offered regardless of the individual's limited or unsuccessful work history or their present status of sobriety or abstinence. The home and community-based employment SUD staff who specializes in substance use disorders and employment rehabilitation work with the individual where they are currently within the continuum of their recovery. The other two others employment support services include intensive employment support and ongoing employment services, and these services support the employed individual. And it helps them to identify substance use disorder triggers, cravings, and relapse, such as stress, time management, and money management, other relapse indicators that occur long before the individual actually picks up and/or relapses, and supportive work considerations such as a request for Americans with Disabilities accommodations, or like requesting time to attend a 12-step meeting, or considering the benefits of further education to maintain their long-term employment or as career advancement as they maintain their recovery with additional stressors. All of the employment services, like the educational services, are face-to-face interventions and can be offered within the treatment, employment program setting, or provided in a location of the participant's choosing, including their home or their workplace. Thank you.
Good morning. I'm Brenda Harris-Collins, and I also work with the Practice Innovation and Care Management Division at OASIS. And I'm going to speak a little bit about the peer-based services. And for us in the substance use disorder system, peer-based services using certified peer advocates, which is different. There's peer specialists in the mental health, and for SUD, it's peer advocates, certified peer advocates. To this point has been clinic-based service. And this opportunity that is being presented for home and community-based services offers an opportunity to deliver peer and other services out of the clinic and in natural settings, addressing the unique needs of the substance use disorder population. A peer advocate is a personal guide, we know, for a SUD individual. But for example, with the empowerment service is chosen by a peer, This may help a peer navigate certain systems which have been challenging to them. For example, there are many barriers that occur when an individual, a substance use disorder individual, has pain management issues and concerns, and they may have difficulty navigating the primary care system. And one of the things that a peer advocate can do can help them really navigate that system and help talk to the doctor, because there's many doctors that primary care doctors that have misconceptions about that, and prescription drug use is a huge problem, and being able to monitor and manage that. And so that's really important. Also, the peer advocate can guide a person through many pathways that are available to the SUD recovery person, and connect the person to the recovering community that is really blossoming at this time. And for SUD, we really are pushing the recovery community to come together, and there's a lot of aspects of recovery community that are available that many do not even know about. But family support services also is an important area for peer advocacy to happen, and it opens up the door. We know that in substance use disorder systems that many people have difficulty with, their family becomes very divided. And this offers an opportunity for reconciliation with the family and helping them to understand the chronic nature of addiction, because many people do not understand the chronic nature and relapsing nature of addiction, and being able to understand that and how to deal with these, the person managing their triggers and cravings during their recovery process. So it's really important that we have these services. This is an excellent opportunity for us, and we're really excited about having these unique service models develop. This is a key process for those, many of the individuals that we're going to talk about are going to have very limited recovery capital, and need help in developing that. Even psychosocial rehabilitation is important in this aspect. As SUD individuals, we will be met where they are and allow structure to be put in place, teaches individuals how to participate in positive leisure activities, and actually follow through with their sobriety goals. And so we're looking forward to how these opportunities will help with stabilizing individuals. Thank you.
Thank you. Before I turn it over to Boris to start to get into the details, there's two other things that I was asked to cover. So the difference between the state plan services and the HCBS services, most of our state plan, let me explain what that is. Right now, most of our mental health services are on the fee-for-service side. From the federal perspective, in order to get those services into the benefit package in New York, the state has to have a, quote, state plan, a Medicaid state plan. So we have a state plan with the federal government. You know, we got clinic in there, we got PROS, we got the SUD services, we have ACT. And those services for people that are going to move into managed care, you know, right now a lot of people you work with, their Medicaid card's a managed care card for their physical health, so they might go to Fidelis, they might go to Health First, but it's still a fee-for-service card for the mental health. We're going to move the fee-for-service benefit package into the managed care benefit package, and on October 1st, their Medicaid card will turn into a full managed care Medicaid card for their benefits. But then we're going to be moving these HCBS services in too, and so what's the difference? So if you take, for example, ACT or PROS, it's a program, it's integrated care. You know, in both of those settings, treatment, rehabilitation, and support are provided together, where the HCBS services are distinct services, so program versus a service. But when you think about it, some of the programs in the state plan address things that also these HCBS services can address. So how do you deal with that? And this is where assessment and care planning really comes in. So I'm kind of talking to the people that are working on health homes and care management now. So let's use an example. So you're meeting with somebody, you're doing an assessment, and the person's got a lot of active symptoms. They've been in and out of the hospital a lot. They have, you know, some of the positive symptoms of psychosis. They had a bit of trouble engaging in their plan of care in the community, but you talk to them in a person-centered way, and what are their goals? Well, I'd like to stay out of the hospital, and I'd like a job. Now, from evidence-based supported employment, no matter who you're talking to, if they say they want a job, you try to help them get a job by helping them to address the things that's a barrier. Now, depending on who the person is, what their preferences are, and the community they live in, and your clinical assessment of that person, that could be addressed in a number of ways. For one person, they might say, okay, they should go to a clinic for their treatment, and the plan of care should be reformulated, and I'm going to refer them to HCBS employment, and maybe they should get mobile rehab too for a while to help them connect their services to their actual home setting. For another person, an ACT team might be right. You know, they may have trouble coming to place-based services. A mobile team that does more real hands-on in a natural environment might be the right person there. Now, you're going to make sure in the ACT plan of care, you're focusing on their treatment for symptom stabilization, but you're also focusing on their employment goal. And for somebody else, a PROS program might be good. They don't really have a lot of trouble getting to a service, but it's clear that if you had you know, the fragmentation of different services, it wouldn't be good for that person, because in order for that person to achieve their employment goal, at the same time, you have to work on their symptom stabilization and on their motivation, and the team approach in the PROS model is the right thing for that person. You got to look at where they live. You might want them to think a PROS program is the best, but there might not be a PROS program in their area. Now, that's not as much of a problem in New York City, but upstate, there's whole areas of the state where we don't have that. So the point I'm making is that the care manager needs to have real deep knowledge of the benefit package, the differences in the services, the communities that these services are in, and engage somebody in a person-centered way. You might think that the best thing for that person's an ACT team, but if they don't want that, you're going to have to work out an alternative. So that's one point I wanted to make. The other is that the care manager does the assessment and the plan of care that's approved by the managed care company, and then the people are referred to the services. But the care manager doesn't have the deep knowledge of all the services from a clinical perspective about intensity and duration. How many times a week should the person be seen, for how long? So when you get to the actual program, whether it's an HCBS or a PROS or an ACT or an OASIS program, you're going to do an in-depth assessment. An example would be several years ago, I fell skiing and I hurt my shoulder, and I went to the doctor and he gave me a shot and he did the medical stuff, and he says, well, I fixed you up medically, but it's clear you got some scar tissue in there, you got a range of motion stuff. I need to refer you to a physical therapist. So his medical knowledge was clear. He said, you need physical therapy to restore your functioning. I've stabilized you medically, but I have to restore your functioning. But he's not a physical therapist. He didn't have the deep knowledge of exactly what a physical therapist needs to do. So I went to the physical therapist, and they did assessment, just focused on physical therapy, wrote up a plan of care. That was approved by my insurance company. And then I went to him for a couple of months, and my range of motion got better, but he thought he could improve it more, so he went back to the insurance company after the initial duration was done and justified that if I came a bit more, my functioning would improve more. So that's what you're going to see. You're going to see the plan of care authorizing the services that you provide. Then when they come to you, you're going to have to really do an in-depth assessment around exactly how you're going to do the services. But the care manager really needs to understand all this. So we're working with McTac. We're going to be doing some in-depth training there. But for agencies that do both care management, state plan services, and now HCBS services, you should be thinking internally about how you train your workforce on all these issues, because in the world of managed care, if it's not in the plan of care, the people aren't going to get the service. You can't pass go without that. So if you're an HCBS provider or a PROS provider or an OASIS provider, and the care managers you're working with don't understand what you do, they're not going to think about it. So that's an important point. So just to conclude my part of this, I wanted to make the point. So we have like this old toolbox with all these state plan services in it. And, we've done some good stuff with them. When I came to the Office of Mental Health, there were 20,000 people in state hospitals. Now there's 2,900 people in state hospitals. But, the readmission rate to Article 28 hospitals is 22% in 30 days. So good result, not such a good result. We've done a lot of good things, but I think we could do a lot better in improving people's functioning and engaging people. There's not a lot of accountability if people fall out of care. our employment statistics are bad, or our education statistics are bad. We could do more integrated care. So I think we got these new, like, shiny tools. We just got this new toolbox, and we're kind of looking at these things, and we want to build this thing, and people are saying, okay, we want to build this new thing, and these tools will help you to do it, but we don't really know how to use them yet. So I'm thinking the first 3 years here, we're going to really have to have a partnership between government, managed care plans, the providers in the plans network, and the advocacy organizations, including the peers and the families, to figure out how we use these tools. And I really believe over the first few years, we're going to be modifying some of our definitions and training. Think of like PROS. We had to tweak that a couple of times to make it work. We tweaked ACT a couple of times and it came out the door. So I think in these first years, we want to really partner with you to figure out how to use these new tools to get the best possible result. And the last thing I wanted to say is, if we do it, I really think we're going to be able to help people improve their lives. Our goals won't just be symptom stabilization and keeping out of the hospital, but community integration, functional improvement, people having good lives and learning how to manage these illnesses and have good lives. And the providers that are going to thrive in the long term are providers that are going to be able to demonstrate outcomes. So you've got to think about how to collect your outcomes. We're going to be doing it. We're going to be making it public. And I said this in the beginning, as you're figuring out how to get to the table in terms of billing and getting in networks, don't wait to think about the quality of the interaction between your workforce and these individuals, because that's going to be your long-term business success, that you could demonstrate you could do the job. So now I'll turn it over to Boris about the stuff you really want to hear about, is how to get to the table. Thank you.
All right. Good morning, everybody. Thank you, Bob. My name is Boris Vilgorin, and I'm with the NYU McTech. I'm the Healthcare Strategy Officer, and I'll go through the key components today. And again, as I think everybody has been emphasizing, this is the beginning of the discussion and introduction to HCBS. And so these are some I guess, of the business rules, or some components that, as Andy mentioned, go across all HCBS services. And we definitely going to need more discussion as time progresses. So Bob really took care of the first two bullets and really the conflict-free in his introductory comments. I'm going to jump right into the exclusions and the co-enrollment rules. I believe we have a slide on that, so we'll get a little more into it. But basically what that means is there are, I would say, business billing rules that sometimes allows you to provide HCBS services in conjunction with some of the other state plan services, and sometimes you cannot. So we'll go through that grid later on. I think that might be in the next slide. As I said, conflict-free, Bob already covered. Let's talk a little bit about commingling as just an interesting term, but what that really means is really for the providers who have both state plan services and HCBS services. And if there was, thinking or desire to somehow offer a group and have folks who are enrolled in HCBS and folks who are enrolled in, let's say, a PROS program, participate in the same group but bill for two different types of services, clearly that is not allowable. So we just wanted to put that out. It makes sense. It's kind of straightforward, but these are some of the questions you get, especially for folks, as Bob mentioned, who offer both of these types of services. So we're referring it to as commingling. The next piece is space. We're not talking about outer space, or there's the final frontier, but I know for a lot of providers, space is very expensive. So we're really talking about shared space within programs. Again, focusing for this particular one on providers who offer state plan services or and are going to be offering HCBS. And the example here is if you have a program that's not running services during a particular time, maybe after hours or during even hours, certain space is available, can you provide HCBS services within that space? Very focused only for HCBS utilizing the space. There'll be more on that coming both from the OASIS and OMH, so we'll be publishing that and providing that information as it becomes available. But we just wanted to put that out there as something that the state is looking at and is thinking about as well, an ability to use the same space, especially if it's licensed and designated space by whatever your licensing body is. The staffing as kind of going through some of the potential sharing. So staffing is another sharing component where you might have a social worker, a rehab counselor, a psychiatrist that might work part-time for your state plan and part-time for HCBS. That is acceptable and allowable. Of course, there are certain programs, I think like an ACT team, that has certain requirements around that. So of course, all regulations and all rules apply, but as long as the staff time is tracked appropriately, allocated appropriately, and so forth, and of course meets all the regulatory requirement, that's okay to continue. And I know a lot of providers currently do that with a number of services where that could be appropriate. And the next one, especially for the HCBS providers who maybe have never billed Medicaid before, there's an emphasis and a reminder that these are Medicaid services, and documentation requirements are going to be followed as with any other types of Medicaid billing, which means you're going to have service notes, progress notes. Bob talked about plan of care, all of the documentation requirements that comes with Medicaid billing would be implemented here as well. So other key components, continuing with compliance and the service caps. I'm going to keep pointing, and I think everybody else is going to keep pointing towards, there is a billing manual, there's an HARP HCBS manual, there's a fee schedule that's on the OMH website. The slides have links, and the slides will be available online. But I strongly recommend folks, if you haven't looked at those manuals, I strongly recommend you take a look at them and really start digesting them. But the billing rules, the more detailed billing rules, and all of the utilization management compliance, a number of them are still being developed, but there's a lot of information already available in both of those manuals. Another question that we get a lot is, do I need an NPI? Do I need an MMIS number? What about the licensing rules in general? So I can definitely tell you, as I think we have said over and over again, if you're going to bill managed care, Medicaid or Medicare, you need an NPI. That's a given. Everybody will need an NPI if you're going to bill that. The MMIS, or also known as the Medicaid number, there are some federal regulations that are being proposed. Some things are still being discussed at the moment. It is not required, but that could change in the near future, especially depends on the federal government and the direction it goes. And then there is basic licensing requirement, meaning like fingerprinting, background checks, as a lot of folks have to do now to get your license, and other types of requirement that's outside of getting any number. And that is being reviewed, and more information is going to come forward. And again, these are predominantly for the providers who have never billed Medicaid and probably do not have experience in NPI, Medicaid numbers, and licensing. If you're a provider who has been billing Medicaid or Medicare, I assume you have a license and an NPI number and probably a Medicaid number. So you're halfway there. I'm not going to spend too much time on the inter-I. There's a whole other training that goes on, the health homes participating and going to be trained on. That's the assessment that was talked about. And then there's the contractual piece that, of course, all the managed care companies and HCBS providers need to contract for the services to be able to provide. And I think it goes without saying the communication is going to be the key component. I think we're going to keep coming back to communication between the service providers, the health homes, and the HCBS providers, and of course the managed care, all together trying to kind of put together a plan of care that's appropriate for the individual. So we have the CMS final rules here, which speak to the setting area that we wanted to touch base. So this is, again, a high-level overview. Depending on individuals' residential setting or where they live, they might be included or excluded from the HCBS services. And that's kind of gives you a little bit of a introduction for where my individuals fall. There'll be more guidance that specifically will talk about the current residential settings, and that will specifically indicate if the individual cannot participate or cannot obtain HCBS services, and those who can. And again, these are CMS rules on the setting. These are not state rules that are provided. And so more guidance will come, so this way particularly you would know if somebody's in the community residence, a CR, are they excluded, are they included, and so forth. They will be still part of the managed care transition as long as they meet other requirements. This is very specific. Do they qualify for HCBS services? So I don't know how many folks can really see this, but again, it'll be up on the website. This is the exclusion and co-enrollment that we talked about that I've mentioned earlier on. This is actually the grid. What it does, it goes through all the state plan services and HCBS services. And if it's blank, that means it's a no. And of course, a yes means a yes. And this gives you a sense and an idea. It's still in a draft form. The final one will be sent out as soon as it's completed to kind of indicate if you're in one of these state plan services, what HCBS services you can and cannot get during this time. So I'm not going to go through this chart in detail. One, it's still in a draft mode, and two is, more information, and I don't even know how many folks can actually see this. So now I'm going to turn this to Dr. Andy Kleek, and he's going to go through what we're referring to, who's on first, and the workflow.
So I get to walk folks through the pictures, so that was my particular lot in life. How many folks have heard on the whole who's on first thing? It's like above a certain age, everybody goes, yeah, and below a certain age, people just look. There are people in our office who just look at us, what are you talking about? You and Boris and your strange jokes about baseball. But we've been trying to think through who's in and who's out of Medicaid. And it's a little complicated sometimes. So I'm going to kind of walk through what we know as of now. The vast majority of this is decided. There's a couple little things that are still under consideration. I want to highlight that all the slides that Boris just went through and the slides that I went through, some of them in red and some of them not in red, say draft on them. That's because they might change a little bit. But also, we're going live in October, so you need to start to do some of this. But they do say draft on them, so just, they're as final as they can be as of today, but there may be some changes. As changes come along, we will come back and update those changes as well. So this is the who's on first slide. Your slide is a little different. The printout, you have a printout in your packet. It's in color. It's the only thing that's in color, but it doesn't look good in black and white. So we printed them all out in color and spent the extra money. There is one minor difference in yours from ours. It has something called buy-in on it. It is a very, very, very small part of the Medicaid population. There's still some discussions between at DOH about whether buy-in is in or out right now. Unless you know deeply what buy-in is, I wouldn't worry about it. Okay, so I'm going to go through the big stuff first, and then the little more wonkier stuff in a second. So all Medicaid state plan services are in managed care. So basically, all the people who used to be outside of managed care, the vast majority of them are now in managed care. There's a couple areas where there is still some folks who are going to be out of managed care, so let me walk through those. Duals are still going to be billed fee-for-service to Medicaid. They are going to be outside of managed care, except for people who are in FIDA. FIDA is the state demonstration project. We're not doing TA on FIDA, so I'm sorry about that. But FIDA is the state demonstration project with dually eligible Medicaid and Medicare clients. They are in a different kind of managed care in FIDA plans. But for the rest of folks who are duals, they are excluded from managed care. and you will continue to bill them fee-for-service for now. That does not mean that at some point in the future that might not change, but for right now, they will continue to be billed fee-for-service. Make sense to everybody? Okay, good. All right, and then for folks who are HARP, they are also in managed care, but the managed care plans are going to have a separate carve out. It would, and in another life they would have called it a special needs plan. Here we're calling it a health and recovery plan. The HARP, they will have a different capitation, which means the plans will get a different rate for those folks, and they will be in a HARP plan. The vast majority of the plans, except for Affinity and WellCare, I got that right? Affinity and WellCare. All of the other managed care plans are going to offer a HARP plan. So if you have clients in any of the other plans and they're HARP eligible, they'll get a letter saying that they're HARP eligible, and they can just stay with what they're doing, and they will move into that plan's HARP plan. In New York City, yes. I'm only talking about New York City right now. But in Affinity, for Affinity and WellCare, they are not going to offer a HARP plan, so if the clients are going to want to take advantage of HARP services, they will have to move to another managed care plan. Does that make sense? Okay, good. So far, so good. All right. Now, if you are in a HARP plan, you are also potentially, and I emphasize the word potentially because of the next couple slides, eligible for HCBS services. Not everybody in the HARP plan will get HCBS services. There's a whole assessment process, which I'm going to walk through in a second. So if you are in a HARP plan, then you can be assessed to be eligible for HCBS services. If the assessment comes back and says you're eligible, then you can get access to HCBS services. There will be people who are in a HARP plan who are not eligible for HCBS services because they don't go through the assessment process. And as Boris alluded to, there's work going on in the background because of the CMS rules that based on the setting in which you live, you may also not be eligible for HCBS services even if you're in a HARP plan. So eventually there will be a very, very concrete list of the different levels of housing and who's in HCBS and who's not in HCBS, and that's not totally finalized yet, but when it is, we'll get that out to folks. But so everybody with the housing exclusions, with the exception of the housing exclusions who are in HARP, will be eligible to be assessed to be in HCBS. Does that make sense so far? Okay, I'm getting head nods, so that's good. All right. The other one that is spend down, that is another, again, a little very, very small population. If you know who spend down clients are and you have some of them, they're in. Okay. The last group is kids. So kids, spend down are out. I'm sorry. Sorry about that. They're out. I misread my own slide. Yes, spend down are out. So the green is out. So the last group here, yes.
Are they out permanently, or once they meet the spend down, can they be in them?
They're out. Okay. The last group is kids. So kids are going to get transitioned in 2017, but in the meantime, they are carved out of managed care. And kids, when they go in, are going to be going in up until kids are going to be kids until their 21st birthday. So everybody between 0 and 21, or 0 and the last day of 20, will be out until 2017. They'll be able to receive any of the services they would have been eligible for under fee-for-service Medicaid, but they're not going into managed care until they turn 21 or 2017, whichever comes first. Does that make sense? Okay. So that is, in general, who's in and who's out. Or as Boris likes to say, and I like to say, who's on first. All right. Helpful? Okay. You have a copy. It'll go up on our website. You can give it to your care managers. You can give it to your staff. They can stick this on the wall. When it no longer sends draft on it, we'll send out another version that's even more official. But for now, this is the general rule. I know we've talked about this a lot. A lot of people have talked about this a lot, but we felt it would be helpful to actually get it down on paper for folks. Okay. So that was the easy part. Now we're going to walk through the workflow of how somebody gets into an HCBS service. So, as I said before, not everybody in HARP will ultimately receive HCBS services. So with the exception of the folks who are carved out of the HCBS services because of where they live, everybody else in HARP will be eligible to be assessed for HCBS services. So we have been working very closely with the state, with OMH, OASAS, and DOH and DOHMH. And I'll try to get a couple more acronyms in there along the way, to figure out step by step how does somebody actually end up in an HCBS service. So there are a couple things baked into this workflow which I want to be really clear about on the front end. This assumes someone is in a health home. Now, we all know that many of the folks who are going to be HARP and HCBS eligible are not yet in health homes. So there will ultimately be a process by which they either get into a health home and they get served or they get assessed, or there'll be some other process. But this assumes that they're in a health home. So you have a client, and we're now live with HCBS, and you're going to start assessing the clients if you're a health home on your care management caseload or in your care management agency, and assessing them for HCBS services so they can access these additional services if they're eligible. The first step in that process is to do the HCBS eligibility assessment, which is a condensed version. It's I'm going to just read this. I never read slides, but I'm going to read this because Dawn will yell at me if I don't get it exactly right. It is a subset of questions from the Community Health Suite of the Inner Eye and other HCBS eligible questions. So it's basically a much, much condensed version of the longer the Inner Eye assessment. So you'll sit down, you're a care manager, you'll sit down with your client, and you'll go through the HCBS eligibility assessment. From there, it will fork in one of two directions. For some clients, it'll come back and say, you know what, they're in HARP, but they're not eligible for any additional HCBS services. For other clients, it will say, yes, they're going to be eligible for HCBS services, at which point you continue to follow this workflow. So if they are deemed eligible for the community assessment, then you conduct the full HCBS assessment, which is the Inner Eye everybody's been talking about. So you sit down with a client, you walk through the full Inner Eye. It'll take an hour and a half or so, and there's going to be some slides in the end about all the training that's available to do the Inner Eye training. How are we doing so far? Make sense so far? Okay. So the Inner Eye assessment comes back, and it is going to give certain domains where people have certain challenges and areas that they are eligible to receive HCBS services. At which point, the care manager in the health home is going to work with the consumer, and collectively, they are going to come up with an initial plan of care. I want to emphasize that initial plan of care might not all be HCBS services. So to Bob's point, they might either be taking advantage of state plan services already that might meet some of those needs, so there's no reason to rip them out of one service and move them over here to another service, or they might be eligible for HCBS services, but a more comprehensive program like a PROS program or an ACT team might be more appropriate because of all their needs. So working with the client, you're going to walk through what are the HCBS services they're eligible for, what state plan services are eligible, and then they're going to develop an initial plan of care. The goal of this whole thing is really to foster communication between the plan, the health home, and the providers. So for those of you in health homes who have been doing this for a long time, the goal of that was also, to kind of coordinate the care across all the different service settings. So this is really focused with the health home care manager as kind of the nexus for the health home care manager to work closely with the plan and the HARP plan. So the HARP is the HARP plan and all the different various service providers to make sure that the consumer is getting the services that they need and that they want. So they're going to work with the consumer to develop an initial plan of care, which will highlight the different services they're going to get. So maybe they're going to go to a clinic, and they're going to get psych rehab and employment services and peer services. Okay? And they're going to look through the lists of in-network providers and identify a couple of them. At which point, they are going to communicate with the plan and the HARP plan, whether it's by phone, whether it's by secure email, whether it's by fax or, smoke signals. However, they're going to communicate. It'll probably be a little different based on the different plans. They're going to communicate with the plan and get an initial sign-off to that plan of care. The reason for that is to make sure that there's an overall agreement of what the plan of care is, and also because the plan is one of the check steps in the conflict-free stuff that Bob talked about earlier. So they're going to get an initial sign-off on the plan of care. So the plan, you call the plan says, that's great, we want the person to get these 3 services, at which point the care manager will refer the client to the services that they're eligible for. So they'll send them to an employee. Now, it would be great if they're all in one place, but let's just say, for the sake of simplicity, let's say they're all in one place. They're going to send them to an HCBS provider for their employment and their psych rehab and their peer services. How are we doing so far? Make sense so far? Okay. After that, the HCBS provider will then work with bring folks in for an assessment, and like Bob actually, it's a very good example, is like PT, right? You bring folks in for an assessment, the PT, or in this case, the psych rehab provider or the peer provider, will do their own assessment and identify intensity and duration. So they're going to say, we'd like to see you twice a week for the next 6 months, or whatever it happens to be. They will fill in the rest of that. They will then call the HCBS provider will then call the plan and say, this is what we want to do with Bob. We want to see him twice a week for 6 months. This is why. And the plan will give them service authorization to do that. And then the HARP will notify the health home care manager of the service authorization, and the health home care manager will update the plan of care. Okay. How are we doing? All right. So I'm going to do one more thing real quick, and then we're going to take questions. Okay. So the conflict-free, Bob and Boris alluded to a lot of this. These are CMS requirements for making sure that people don't get steered in one direction or another, okay? So that, for some reason that all the clients are going to one health home care management agency only get services at that health home care management agency. The state, the CMS, and everybody really is very concerned about that. There's CMS requirements for making sure that doesn't happen. The biggest one of which is to make sure that when people get referrals that they get a choice of at least 2 providers to provide that HCBS service that are local and near them and all that other kind of stuff. A care manager can give them more providers if they're available in their area, and at the end of the day, it is always the consumer's choice of where they want to where they want to go and get their services, but they have to have a choice of at least 2 providers. Okay? All right. So that is the plan of care. I think we're going to take a couple minutes here to take questions on everything from hello until we've gotten to here today. So.